Thank you very much, Professor Hess, for that excellent presentation of a number of aspects of care that are important, not only the surgery and radiation technique. So you mentioned surgery and radiation technique and the quality of the application of the initial curative treatment. You mentioned the ability to modulate toxicity, so toxicity modifiers, and you spoke about chemotherapy and the risk factors that have been established over time, and how that chemotherapy might be scheduled, the schedule and administration. So you've set the stage for a number of very important points for us to follow up on in the discussion. I would first like to ask the panelists and the audience, and please feel free to step to the microphones, if you all agree on what are the high-risk factors. Now, if one looks at the EORTC trial, included as risk factors in that study were perineural, perivascular involvement, lymph nodes at levels 4 and 5 for oral cavity and oropharynx lesions, in addition to the positive margins, extracapsular extension, multiple nodes, and also there is literature on oral cavity T4 lesions as being high risk. So maybe I could ask each one of you to comment in terms of your own institutional practice. What high-risk factors do you consider appropriate for radiochemotherapy to be used post-operatively?
Well, we perform post-operative radiochemotherapy in patients with extracapsular spread, with small margins, large tumors, and in patients with more than 3 lymph nodes. But we adapt to the knowledge we have gained from the 2 large studies from Bernier and Cooper. We have no own prospective study to investigate the risk factors. There is a third study which is closed some months ago, but final evaluation is awaited, from Germany with 450 patients, and I think the preliminary data show a very similar outcome.
And what were the risk factors for treatment with chemoradiation in that trial?
Similar.
The ones that
yes,
you mentioned?
Yes, more than 3 lymph nodes, small margins, and large primary,
okay.
T3, T4.
And you would, even in the absence of extracapsular spread of disease, for multiple nodes, you would employ
yes,
the combination?
I would vote.
All right. And Professor Ambrosch?
We would argue for a simultaneous chemoradiotherapy in an adjuvant setting when there are positive resection margins, despite a re-resection in our setting. And if there are lymph node metastases with extracapsular spread. And this is, with this comprehensive data analysis of both studies, the Cooper study and the Bernier studies that appeared in Head and Neck last year, these were the only 2 factors in this comprehensive data analysis from both studies which proved to be significant risk factors.
Okay. So if someone had positive nodes but not extracapsular spread, you would not necessarily add the chemotherapy? You would just go...
Yeah, there's a question. We would
just
go for the extracapsular spread. Maybe when additional data are published, then that more than 3 nodes or 3 and more should be another indication.
Okay.
Yeah.
Professor Zielinski?
Well, there's nothing more to be said from my viewpoint. However, we have one analysis made which is slightly provocative, and I'm sorry, but I'm a medical oncologist, so I'm allowed to say this here. One of the major risk factors we find is the surgeon and the surgical procedure. I think that has been shown very nicely by Professor Hess. And we find that interdisciplinary assessment and interdisciplinary treatment reduces the risk of the patient. This was done retrospectively with wonderful cooperation with the ear, nose, and throat division at our hospital. And there we do have this interdisciplinary cooperation. And there we have definitely much better results than in other scenarios where this interdisciplinary treatment is not taking place. So I think that is something which has to be discussed. And we know that. This is no surprise. We know this from rectal cancer, for instance. In rectal cancer, the surgeon and the surgical procedure is one of the major risk factors. So, and probably it's a bigger risk factor than can be neutralized by adjuvant radiochemotherapy.
Yes.
So I want to really draw your attention to this fact and to the point that was shown here.
In Göttingen, we have a continuing discussion about the risk factors, even with my friend Wolfgang Steiner. The reason is that we all know the risk factors for recurrence. But another point of view is whether radiation therapy significantly increases local control in which group of patients. And if you look at the data of Bernier, for example, the subsets are not of sufficient size to prove a significant difference. I think the patient number is insufficient for proving significant differences plus minus radiochemotherapy in this setting. So there is continuing discussion about that because the data available are insufficient about this question. And one important point in the discussion always is the benefit-risk ratio. With improving radiation techniques, I think we should treat more patients because even in N2 or N1 neck, radiation therapy may be effective in the rate of local control. And the reason that we do not treat these patients is the toxicity of treatment. So I advocate to have decreased toxicity of patients and not to increase, for example, chemotherapy in intensity if you are not sure that you improve local control or survival.
Professor Wendt?
Yes, there's probably one subset with high risk. I would also recommend chemoradiation, but it's a small group. It's the patients with the metastasis in the level 4, which these patients have a very poor risk. But this is not established. I think this is an individual decision to be discussed with the patient.
Comment from the audience?
Can I make a comment?
I have a question. Is there any experience with the use of keratinocyte growth factor in this setting to prevent mucositis?
Yes, we have that. And that works well. It was recently adapted. We're part of this phase 3 trial, which was done by Amgen, and that works very well. Besides, there was a lot of previous experience with the use of oral solutions with GM-CSF, which also works nicely.
We have experimental data with this growth factor, and probably there is no effect on tumor growth if you give that, but you should be very, very cautious. If you look at the data with EPO and with GCSF, you should be very, very cautious with giving this keratinocyte growth factor. I think outside it should be not given without clinical trials. And even within clinical trials, you should be very, very cautious.
Yes.
Can I comment on this, Henke? This was discussed like 100 times in different scenarios and different panels. But I think there's one point that has to be made, and that is Dr. Wennerberg mentioned yesterday this very nicely, that one of the major problems patients with cancer have is fatigue. And of course, therefore, you have probably to look at two different aspects. One aspect is whether you want to maintain hemoglobin levels, and the other is whether you want to increase hemoglobin levels that went down due to chemotherapy. And of course, the Henke paper addressed the first aspect rather than the second. And therefore, probably one has to look at these things a little differently.
But the best way to maintain a high hemoglobin level is to reduce surgery. It's less expensive and it's less dangerous.
And it's probably reduced dose of cisplatin. I often see anemia due to...
Let's hold on the chemotherapy dose discussion, and let's hear from the audience. Dr. Shaw?
I'll just make a short comment. Reducing surgery does not reduce blood loss. It should be reducing bloody surgery. So let's make that correction. Open surgery doesn't mean blood loss. You can do head and neck surgery without blood.
Yeah, that's true.
For years of any extent of surgery, from dura to pleura, do not need blood transfusion. So the concept that open operation causes blood loss is wrong. I'm willing to challenge that. Okay, let's come to the discussion on this. The purpose of concurrent chemo and radiation therapy, as we see from the 2 last randomized trial, is reduction in locoregional failure and probably reduction in distant metastasis. Therefore, we need to identify a group of factors and not 1 or 2 isolated factors which put the patient at increased risk of locoregional failure and or distant metastasis. And they are related to the primary tumor and the neck nodes. We can't combine them and say, if I have extracapsular disease, I will give adjuvant chemotherapy. I can give you an example. You have a T2N1 patient with a 2 centimeter lymph node at level 1, focal extracapsular extension. Show me the evidence chemotherapy will add to that patient's benefit without increasing morbidity. So we can't combine that. We should develop in future is a prognostic score of increased risk of local regional failure and increased risk of distant metastasis for future trials. For example, a T4 primary, any site, positive margins, perineal invasion as they relate to the primary tumor, N3 disease, large volume N2B disease, low neck disease, or extranodal extension as nodal factors. This should be put into a multivariate prognostic factor score, and a combined score putting the patient at high risk should be the entry criteria for adjuvant trials in future.
Thank you. I think that's a wonderful comment, and helps with our discussion about where we should go with this whole concept of improving disease outcome with adjuvant therapy. Next question, please.
Yes, please. I would comment on the Henke study and the EPO results. And, the adverse effect of EPO was found in the subset of patients with positive margins. And we have been looking at EPO in vivo and in vitro on squamous cell carcinoma and find no effect on tumor growth unless you inflict a surgical trauma to the tumor. If you do that and give EPO at the same time, you enhance the growth of the tumor. So I would be very careful to give EPO in a contest with surgery and of malignant tumors.
But as a corollary to that, in the as a supportive factor, a supportive growth factor for patients with anemia outside of the surgical setting, you do not see a problem with that?
Well, no, this is experimental studies on tumors on nude mice. And when we do surgery on the tumors, you just cut it with a needle and give EPO. You get enhanced tumor growth. Mm-hmm. And it's probably not a direct tumor cell effect. It's a stromal effect. That's why you need an in vivo model to see it.
Okay. Thank you.
I would like to make 2 comments. The first on the problem of risk factors. The problem with the pooled analysis is that it only gives positive results. You cannot exclude something by the pooled analysis. So the positive one is we know that the patients with the extracapsular extension or R1 resector ones, they will benefit most probably. But we cannot exclude, on the other hand, that the ones with more than 2 or large 3 lymph nodes will not will not probably benefit because the subset analysis is not powered to detect these differences. So we are left quite alone on an individual decision basis for those patients, and this is how we treat them in Tübingen. The second comment is to Professor Zielinski, who stated that KGF has positive effects in the setting of irradiation. To my knowledge, at least the phase 2 trial by Amgen did not show positive results, and the results of the ongoing phase 3 trials are not available, so we don't know that. To my best knowledge, KGF has been useful, has proven usefulness for the mucositis in the allogenic transplant setting, but up to now not in the radiation setting.
But it reduces very impressively mucositis in the setting. Very impressive.
We have the feeling as well we're participating in the trial, but the data are not available.
Well, I can only tell you that when you do bone marrow transplants and you use this factor,
but I think
very impressive.
But we have to be careful to compare the mucositis, the pathogenesis of mucositis in a GVHD setting with the mucositis after radiation. I mean, this is quite a difficult comparison, and the phase 2 for radiation with KGF was not positive. So before really claiming that KGF helps in the radiation setting, I think we have to wait the results of the ongoing Amgen trial. I mean, in our hands, we have the feeling that our patients receiving KGF do a little bit better, because I mean it's a blinded study, but a clinician quite fast finds out who gets the KGF because it increases facial swelling. But anyway, we have no clear-cut data on KGF in a adjuvant radiation setting.
Well, I think it's encouraging that a randomized phase 3 trial is ongoing with KGF. It is the drug out there that at least has preclinical and some supportive data to make it the feasibility has been shown, and the potential for being a toxicity modifier for mucositis is much greater than with amifostine and other drugs looked at to date. Yes, please.
Silverati from Belgium, Ghent. I have the question for the radiochemotherapy in the adjuvant setting. Is there a place for, I know there are no data, but is there a place for carboplatin? I mean, a patient in a good performance status, but with a creatinine clearance of 50% of the normal value. What do you think about?
Okay, that's a great question to open the discussion now about, get back to the discussion about the chemotherapy that would be given with radiation. And we heard from Professor Hess that at his institution they use the Jaramak regimen of the 6 milligrams per meter squared per day of cisplatin. And I take it that you do that because you see less toxicity, not less mucosal toxicity, but less other systemic cisplatin-related toxicities. Okay, Professor Zielinski, what is your opinion about?
Well, I think we have a couple of schemes and a couple of regimens which are out. However, I see some kind of difficulties in comparing them because there's very few head-to-head comparisons. What is doing what? Nevertheless, I would be very careful about modulating regimens which have been proven useful in dose or whatever, because I'm very ecclesiastic about that chemotherapy regimen should not be modulated as long as it's not necessary and as long toxicity is not manageable. That is because we do have data which are built upon certain dose intensity, and certain drugs. And in my view, it's very, very dangerous to extrapolate from other tumor entities or from other regimens the efficacy into a certain disease entity. So I would be very careful about that.
So you would use the 100 per meter squared as was used in these two trials?
I would think so, because that is something which has been researched quite well, and I see not very many weaknesses in these trials.
Okay. What about carboplatin? Are there situations where you might substitute carboplatin, or would you just choose not to treat the patient with the chemotherapy?
Well, again, I would rather adhere to what is out. And again, what was said before, in fact, that is similar, the scenario is similar to non-small cell lung cancer, where carboplatin is out and it's much nicer to use probably. Although recently there's a lot of reports about toxicity of carboplatin concerning some kind of allergic reactions, which is coming out more and more. So this is something which we will have to watch very carefully. So this might be not that an easy drug to use as we thought until very recently. Nevertheless, cisplatinum is obviously the better working agent in this in this disease, as it is in non-small cell lung cancer, where there's a lot of similarities, I believe.
Professor Ambrosch, any comment?
No comments on this.
Okay.
I'm not responsible for the dosages. This is a question for the radio-oncologist.
Professor Van?
Yes. Professor Hess pointed out the importance of hemoglobin or oxygen situation for the tumor in the primary radiochemotherapy, but also in the post-operative setting. And I think it is worth to think about how to find a protocol combining the efficacy of cisplatin, but probably also to reduce the propensity of producing anemia. And probably the Yeremich data are very good due to a different profile of anemia with the low dose cisplatin 6 milligram per day, every day. It is worth to investigate that and find a protocol which produces a low rate of anemia.
So you're concerned about hypoxia. Just to expand a little bit, so what do you think about some of the hypoxic cell sensitizers? Do you think that they should be studied in this arena, this particular post-operative setting?
This is a great issue. We are debating in our radiobiologic circles since 2 decades, and we did not come to an end. There is no doubt that hypoxia contributes to worse prognosis, but we did not find any way to overcome that. Even the modern imaging with the MISO, PET, etc., where we try to adapt a radiation dose to the area with hypoxia, I'm very skeptic that this will lead to an advantage. So I don't have an answer how to manage hypoxia today.
Professor Hess?
I think the most important thing is local perfusion. Local perfusion. And after surgery, that's the point for the surgeon. And I don't think that drugs will have a great effect on that problem, because our aim is to improve local control. EPO has not been given to decrease distant metastasis, but to improve local control. And the best way to have good local perfusion is minimal surgery.
Okay. Comments?
I would be a little bit careful to conclude that anemia is the result of surgery on the one hand and chemotherapy on the other hand, and in particular to conclude that anemia is the cause of a bad result in local control. It may well be that the inflammatory process, which is intrinsic to the neoplastic disease, the cytokine excess, which is the result of a neoplastic process on the one hand, and the inflammation caused by surgery but not by the quality of the surgery, is the reason for getting anemia, and in particular simultaneously for having a bad local control, because we know that the cytokines released by wound healing and so on are stimulating tumor growth. So it's a little bit simple to argue that anemia caused by either the surgeon or by chemotherapy is the result of a bad local control. As much as I do know, there is no direct evidence that increasing oxygen levels in the serum or hemoglobin levels in the serum directly has ever altered the response. So I think this is premature to conclude.
Thank you.
Yes, I would like to comment also to the point hemoglobin and surgery. I have to agree to Dr. Kreil, and I would like to just explain some investigations we did. We saw that anemia, but it's not really anemia, it's a hemoglobin lower than 13.5, really causes a bad outcome in comparison to the better hemoglobin. And we saw that this is an effect which probably is related to the aggressiveness of the tumor by itself. It hasn't to do anything with the therapy, with the surgery, and it's not to be influenced by EPO or by substitution after a more invasive surgery. It's just a kind of epiphenomenon we see. If the hemoglobin is very high before start of therapy, we have a better outcome. So it's just similar to the other risk factor, tumor volume, which correlates also very well, independent of surgery or which kind of therapy we do. I think this has to be kept in mind very carefully. And I just would like to point another thing, because Dr. Hess comes from Göttingen and Wolfgang Steiner is here, and it's quite interesting if you do organ-sparing surgery for functional outcome. Your speech therapist, Dr. Kruse, says that for good functional outcome, the enemy of this is the radiotherapist. So he pronounces that surgery is the most important point. You should be very careful and have safe margin on the primary side, and be very careful with adjuvant therapies because of functional outcome. So I would like to have a discussion on this.
Yeah, das würde ich dann machen.
I would make two comments. First, yesterday I showed the data of the functional outcome after laser surgery and radiation therapy, and we have about 80% of functional preservation. Second point, I showed the data of hemoglobin levels before surgery and after surgery. And the hemoglobin levels before surgery had no effect on survival, but the hemoglobin levels after surgery had effect on survival, and probably the hemoglobin levels are an indicator for the aggressiveness of surgery. So I don't agree with your statement. The data, the very limited data, because they are retrospective, etc., I think we have to conclude, if we take this data, we have to conclude otherwise.
Other comments from the panel?
Yes, I would like to give an additional comment on this market statement that the radiotherapist is the enemy of function. Yeah? I would say it's a task of the surgeon to first to remove the tumor completely. Yeah, in the primary site and in the neck. Otherwise, if gross disease is left, the patient has a very poor prognosis. This is the task of the surgeon. Then the surgeon should try to do this with minimum blood loss. Whether he does this with an endoscopic approach or by other methods. Yeah, this is the task of the surgeon. And the task of the radiotherapist is to produce as little as possible side effects. For Professor Kruse, as a phoniatrician and a speech therapist, yeah, he sees slight edemas. These slight edemas reduce the voice. This reduce, in his opinion, function. But the question is whether this is so relevant for all these people swallow. And I have never seen, over this 15 years in Göttingen, that a partial resection, that the laryngeal remnant by adjuvant radiotherapy was destroyed by the radiotherapist. So I would say, surgeon, very careful, slight, less invasive surgery, and a good radiotherapy with not so many side effects. That's the way
well,
to go.
I have to say, I'm not aware of function data with post-operative radiotherapy. I think we've taken that as a given, as a standard of care, and we've not looked at function. Certainly with the addition of chemotherapy now, we are more concerned about function and quality of life and that interplay. Yes.
I would just like to come back to the question of anemia and hypoxia. I know it's a wide field, and if we go into it, we probably sit here until Sunday evening. But I think the big problem is the radiation oncologists grow up, as I did, that the fact that the lack of oxygen influences the outcome in an in vitro setting. And the second point, as we know, anemia as well seems to be correlated with the outcome of the patient. The problem is what we still not know is the direct correlation between an artificial modulation of anemia, pharmaceutically or by transfusion or by anything, if this really changes outcome. And there's one very provocative study or data set being presented on the Astro last year from gynecology, and Patricia Eiffel checked in a data set of approximately 1,000 patients with cervical cancer the correlation between anemia, tumor volume, and outcome. And after correcting for tumor volume, anemia was not longer a significant parameter controlling outcome. So the story between anemia and tumor control is, from my point of view, at least more complicated as we still believe it is.
Well, I think the amount of discussion we've had on this certainly supports that it's a very complicated issue and it's not black and white. Yes?
Just a last comment to the anemia story. There are at least 6 to 7 different leukemia subtypes and lymphoma subtypes which never undergo surgery, and where independently anemia at the start of diagnosis is an independent risk factor for overall prognosis. And this is not restricted to lymphoma. This is seen in many other tumors. And again, what you describe is no causative correlation. You demonstrate descriptive data of a correlation, but this does not prove any biological or functional correlation. And again, I would like to state that surgery is an extremely immunosuppressive action. That's definitely clear from experimental surgery. And the degree and the volume you have to surgically resect, and which is defined by the tumor, is decisive over the degree of cytokines which are released. And it's definitely clear from experimental surgery that this is stimulatory to the tumor. So this is not, in my opinion, a matter of quality of the surgery and must not be correlated with blood loss during surgery.
Yes.
There's data from Cather Miller's laboratory that erythropoietin works similarly as VEGF does in vitro. So one has to be probably very careful, as you say, has to be very careful and consider really and try to weigh the need of erythropoietin versus quality of life. And the Henke data show very nicely how careful one probably has to be, no matter how we decide to go. But that is something where we probably will probably have to weigh quality of life versus effect of erythropoietin versus detrimental effects of erythropoietin when you try to maintain hemoglobin levels above a certain range. That's how I would see that. So I think, as you said, there's no black and white.
No. So we're running short of time, but I would like to close with getting the panel's opinion about one thing, and I'm just going to interject as a follow-up to Professor Zielinski's comments and the audience that there is this very rich cytokine milieu within the surgical bed, and there's some thought to using anti-angiogenesis factors at that time point because one can imagine this whole proliferative and extremely rapid, we know that there's an extreme rapid proliferation rate of any residual cells at that point in time within this cytokine-rich tumor bed. So there are very interesting concepts out there. I'd like to ask the panel to just each one briefly comment, just maybe a sentence or two, about where you think is the most fertile role for us to move subsequent to where we are with the cisplatin radiation post-operative, keeping in mind that that one of the indications is multiple nodes, and we know that that's associated with distant metastatic disease, and yet neither of these studies, the Bernier or the Cooper study showed any impact on distant metastases of the high-dose cisplatin. So maybe we'll start at this end with Professor Zielinski.
Well, I'm very fascinated by the EGFR signaling pathways. Whatever that might be, PI3K, AKT, MEP kinase, PKC, whatever you would like to mention, I think is worthwhile testing in this context, particularly in interaction with the platinums, because there seems to be a very, very interesting interaction in this context. So I think that's where the area probably should be tested, at least in randomized clinical studies.
Professor Ambush?
I would say for me, the reduction of the irradiated volumes, this is a question for the future, whether it's possible, not always, for example, to irradiate the contralateral neck. To reduce the fields and thus to reduce the side effects.
Okay.
I have a similar opinion. Two options. First, also the EGFR strategy, and second, IMRT with more well-defined irradiation volume.
Thank you. Professor Hess?
I think it would be very hard to improve survival, even with the new drugs. Therefore, we should focus on the reduction of side effects, and the problem of volumes and of sophisticated local regional treatment is of utmost importance. And I think we have the techniques at the moment to do that, radiotherapists and as surgeons as well.
Okay. Thank you all very much.
Thank you.